Good morning. Welcome to the last day of the conference. My name is Bill McLean. I am a MEDI MTC, and it is my great honor today to introduce to you Dr. Julianne Sosa. Dr. Sosa is an endocrine and oncologic surgeon at the University of California in San Francisco. She is also the chair, Department of Surgery, and professor at the Department of Surgery and Medicine. She had a previous position at Duke University in North Carolina, and she is a principal investigator or co-principal investigator of studies of new drug treatments for differentiated thyroid cancer, medullary thyroid cancer, and anaplastic thyroid cancer. We're going to hold all the questions until the end. Thank you very much. Enjoy the seminar.
Thanks so much, Bill, and good morning, everyone from San Francisco, California. It's pretty early here, so you're going to see me drinking coffee. I have to say, it could be midnight, and I would have the same level of energy, passion, and enthusiasm about spending time with ThyCa today. I was going back in my files to look at prior presentations to ThyCa, and I realized that I've been doing this for nearly 2 decades. And I've been doing it that long, almost every year, not quite, but almost every year, because I think an important mission of any thyroid cancer surgeon, physician, clinician is to serve their patients. And I think it is such an important role that ThyCa plays in bringing together, in really quite an intimate setting, patients and hopefully thought leaders in the field. And so I'm going to be sharing some sort of semi-top secret stuff that I think will be of great interest to this group. It's still very early in the process, so there's some ambiguity, and we're still in the draft stage. But I think it is going to be a privilege to share that work with you. And I have the privilege of sharing this work in my roles at the American Thyroid Association. I think the American Thyroid Association is the preeminent society made up of members who really dedicate their lives to all things thyroid, and that definitely pertains to thyroid cancer. So I am the president-elect of the American Thyroid Association, for full disclosure, but the role in which I'm speaking today is as co-chair of the committee that is writing the next iteration of guidelines for adult patients with differentiated thyroid cancer. And in this talk, we're going to look backwards a little bit first about where we have been and where we are in terms of guidelines for practice in this area. And then we're going to pivot and look forward to try to anticipate where we might be going next year in 2023, when those guidelines are anticipated to be published. So the title of the talk, a preview of preliminary work done for the next iteration of the ATA guidelines for differentiated thyroid cancer. But I took the liberty of changing that title a little bit because we as a committee are still working super hard as every day new evidence comes in, and our goal is to continue to synthesize that contemporary evidence to inform the way we practice in the field of endocrine oncology going forward. So the new title is What Might Be New in 2023 in the next iteration of the ATA guidelines for differentiated thyroid cancer. And that otherwise may be known as the way too early pregame show. So these are my disclosures, and they really pertain only to the arena of medullary thyroid cancer, where I do a lot of research. So they in no way pertain to the content of today's conversation. So maybe we'll start here. This is a super famous figure, very interesting figure that summarizes 3 decades of experience with differentiated thyroid cancer in the United States. And what I used to say, which I no longer say, is that I literally used to say there's a pandemic of thyroid cancer in the United States. But in 2020, I stopped saying that because we actually do have a pandemic. So I instead used the word epidemic, and it definitely is true. We've had an epidemic of thyroid cancer in the United States, whereby the incidence of the disease over 3 decades increased by more than 300%. I mean, it's crazy to think about. And what is interesting about this epidemic is that it was seen to impact virtually every demographic subgroup of the US population: men, women, young, old, adults, and children. And the reason I used to use the term pandemic is what is true in the United States was also being seen in virtually every developed and developing country in the United States. So there's been a lot of energy over the last several years, and this is a good thing, thinking about thyroid cancer, what is the genesis of this epidemic, and more importantly, how do we treat all of these new patients who have been diagnosed with this disease? And how do we govern that? The way we govern it is through guidelines. And nowadays there are guidelines for virtually every disease process known to man. And I think that's a good thing as long as they are informed by evidence. And if I were to summarize how we have thought about and managed thyroid cancer in the United States, I would say where we are today in many ways resembles where we were 30 or even 40 years ago. So what is governing current practice in the arena of differentiated thyroid cancer? And for those of you who are new to thyroid cancer, and that's okay, differentiated thyroid cancer are those thyroid cancers that are derived directly from the thyroid follicles or follicular cells. They are iodine avid. Okay, so this is not medullary thyroid cancer. This is not poorly differentiated or undifferentiated thyroid cancer. This is papillary thyroid cancer. It is follicular thyroid cancer, and it is Hürthle cell cancer. And the way we manage patients is based on these guidelines that were published by the ATA in 2015. Now, the National Comprehensive Cancer Network also issues guidelines. I am not on that group, but I would say if there is one or the other that prevails or is predominant, it is the ATA guidelines. And these are publicly available. So if you go to the American Thyroid Association website and you click on guidelines, you will find these. And that's kind of useful, I think, for patients, because there are recommendations. The recommendations there are easier to understand perhaps than the evidence supporting them. And they are things you can take with you to clinic when you deal with your clinician to inform the discussion, to help you ask questions. So I really would recommend taking a look at these. And these are the authors of the guidelines. And I always talk about authors of guidelines because I believe strongly that all of us, even those of us who are scientists, have implicit bias, meaning deep down, we have some bias about what we think is right. Maybe it's based on where we trained, how we trained, who we work with, where in the country we work. And so before looking at evidence and reading recommendations, it's important to see who wrote the guidelines, because that may tell you a little bit about what implicit bias you might see. So when it comes to surgery in the United States, these are the authors of the current guidelines. You probably recognize their names and their faces. 2 are otolaryngologists. 2 of us are endocrine surgeons, general surgeons. 2 of us were on prior guidelines. 2 of us in 2015 were newbies. You can see a lot of equity, a lot of parity the American Thyroid Association is thinking about, but of course, we're still working on gender equity. So what drives guidelines? And I think this is really important. And I would say for decades, guidelines that have been written have shared many principles. We want to improve survival of patients, right? We want to reduce the risk of recurrence and metastatic spread. We want to facilitate surveillance. And we want to permit accurate staging of disease. But if I were to say to you, there is one principle which is relatively new and which actually is driving more and more of how we think about differentiated thyroid cancer, it is this last one: to minimize treatment-related morbidity. What does that mean? It means to do no harm. If we are treating a disease that is indolent, meaning where survival overall is excellent, which fortunately it is for differentiated thyroid cancer, we want to make sure that the benefits of the treatment we expose patients to is not outweighed by the risks associated with those treatment strategies. I think it's a very different risk-benefit ratio for diseases where mortality rates are very high, where patients may be willing to accept more risk to get that benefit. With differentiated thyroid cancer, the benefit really must outweigh the risk. So it's just something that is an underpinning of everything we think about. So is that super novel? Well, maybe not for most clinicians, because each and every day in our clinic, on the one hand, we're trying to avoid overtreating disease that in the end will not impact patient survival. But at the same time, we can't undertreat those cancers that could shorten a patient's life or reduce their quality of life. And how do we do it? You know how we do it. Your doctors talk to you about misdiagnosis, not knowing what's going to happen in the future. More and more, fortunately, we're asking you what you prefer. We have to weigh the medical legal environment that we work in, and more care, for better or worse, is driven by cost. So what are the current recommendations around differentiated thyroid cancer? So I just wanted to get us all on the same playing field before we talk about the future. So here's a guideline from 2016. This is the guideline that pertained to papillary thyroid microcarcinomas. So these are for cancers that are less than 1 centimeter in size. So these are super tiny, smaller than an M&M in the thyroid. And as many of you may know, up until 2016, the recommendation here was to do thyroid lobectomy, meaning removing half of the thyroid. Now, there are a few exceptional cases where we recommend taking the whole thyroid out. You could say, well, what would those be? Those are things like if you have received radiation to your face, neck, or chest, particularly in childhood, that puts your whole thyroid at risk. And another reason would be if you have familial papillary thyroid cancer, which we call familial non-medullary thyroid cancer. In patients with that disease, they inherit their papillary thyroid cancer. It typically is multifocal, meaning occurs in many different places in the thyroid, and the prognosis is less good. So we are more aggressive. So in 2016, the guideline continues to be lobectomy, but a lot of people missed the insertion of a single 2-letter word. And it was a critical insertion, and it said, if surgery is chosen. And what that did in 2016 was open the door a crack to allow patients who are compliant, where follow-up is robust, to actually have their thyroid cancer left in their thyroid and to be followed very carefully. We call that active surveillance. So that was a super novel concept that was introduced in 2016. And just forewarning, I suspect you will see that little door that was opened a crack opened even more in 2023. Well, is the evidence really good to inform what we recommend in guidelines? And I would say there are some diseases like cardiovascular disease, heart disease, where the diseases are super common, high blood pressure, heart attack, stroke, that they can have studies done of 25, 50,000 patients, and the evidence is super robust. But because thyroid cancer is not that common, I think the unfortunate truth is a lot of the evidence that supports what we recommend is quite frankly kind of thin. Well, this may be one area where it is less than. And this is the age-old debate for differentiated thyroid cancer of whether for tumors 1 to 4 centimeters in size confined to the thyroid without metastatic disease, should we take out the whole thyroid or should we take out half the thyroid? Okay, this is a debate, argument, yelling, screaming that has been going on for decades. Okay, and there have been historically two camps. Those who argue you need to take the whole thyroid out say, often papillary thyroid cancer, for example, is multifocal up to 75% of the time. Sometimes after surgery, we want to give radioactive iodine. You need to have taken the whole thyroid out for that to be efficacious. And if you zero out a thyroid globulin level, it's easier to follow a patient. Those who counter and say, let's just take out half the thyroid, say, who wants thyroid hormone supplementation, let alone thyroid hormone replacement therapy? In the end, differentiated thyroid cancer is an indolent disease, meaning people live a long time, often, usually normal length of life, so the prognosis is excellent. More surgery means more complications, and in the end, prove that there is a survival benefit. Well, what have we done? What have the guidelines recommended in the face of all of this debate? Well, back in 2009, so this is now 13 years ago, and up until 2009, the clear recommendations were take the whole thyroid out. And that's the way I grew up, way I trained, what I learned in medical school is that you have to take the whole thyroid out. But a lot of people over the years scratched their head more and more. And you could say, why were they worried about that recommendation? And what you realize is how thin evidence is in thyroid cancer research. And if you go back and look at the literature, there was basically one study and only one study that supported that recommendation to take the whole thyroid out. And based on that one study, the ATA and everybody else said take the whole thyroid out. And this is the summary table. It's not hard to understand. I'm just going to cut to the chase and show you the principal finding of that study. And this is that principal finding, which compared survival for patients who'd had half their thyroid out compared to the whole thyroid for low-risk differentiated thyroid cancer. Again, 1 to 4 centimeters confined to the thyroid without metastatic disease. This is the overwhelming majority of patients with differentiated thyroid cancer. This probably pertains to 75 to 85% of these patients. And what you see is the data suggested people die 31% more often if they have a lobectomy as opposed to a total thyroidectomy. I think all of us would agree, my goodness, that is compelling, right? Well, after that study was published and after those guidelines in 2009 were written, many of us, including myself, said, I just don't believe it. I don't believe it. And a lot of us felt that the study, not the scientists were excellent, but their data was flawed. The database was limited. And then data started to emerge, smaller studies that could not replicate their findings. So my claim to fame, if you want to know how did Dr. Sosa get anywhere in life, it was probably started with this study published now several years ago that basically redid that Bilimoria study. But we were blessed in that we had a better database, their database, but augmented with more considerations and more variables that ultimately almost certainly impact survival. So these are all the things we were able to incorporate into that database. But basically, cutting to the chase from our study, 62,000 patients with differentiated thyroid cancer across the United States. And again, we compared lobectomy to total thyroidectomy with regard to survival. These are all the variables that Bilimoria in 2007 did not have, but we were blessed to have. And as you will see, many of these things totally have a strong impact in survival, which is almost certainly the reason why his group's research group's conclusions were flawed. And the bottom line is when we compare total thyroidectomy to lobectomy with regard to survival, there is no difference in survival between the two surgical strategies. Very different conclusion, right? So what happened in 2016 and where are we today? We're in a totally different place. And that is lobectomy and total thyroidectomy are equivalent with regard to the survival benefit they offer. And in the end, it is the patient, it is all of you that needs to make the choice of which surgical strategy to pursue based on your values, your preferences, and your life truth. So there is no right or wrong answer, except for each individual patient, there is a right answer, and that is based on your unique circumstances. Well, what has been the impact of guidelines? You could say, well, who cares about these guidelines? They're kind of esoteric. Does anyone read them? And does it impact what we do? It totally does. Okay, it totally does. So since the publication of those 2015, 2016 guidelines, what we see is that we have flattened the curve. Now, I know everyone uses flatten the curve with COVID, but we have literally flattened the curve of this epidemic and curbed this explosion in the incidence of this disease. And that's by making sure that doctors are not overstudying patients, meaning doing too many imaging studies. And if we're not overdiagnosing patients, we are also not over-treating patients, by which I mean giving a risk-benefit ratio to patients. Remember that risk-benefit ratio that I showed you, where they're being exposed to more risk than they are benefit. And this is really unheard of in epidemiology, that in such a short period of time, guidelines have impacted how doctors practice. So I think this is another way to look at it. This is a study that I did together with an epidemiology group at the National Cancer Institute, looking at trends in how we manage papillary thyroid cancer. And papillary thyroid cancer now accounts for over 90% of all differentiated thyroid cancer in the United States. And again, I'm just showing you sort of the principal figure from each of these studies, and they're not hard to understand. So these are trends over time from 2000 to 2018. The panel on the left are the low-risk tumors that represent the overwhelming majority of patients, people like you with papillary thyroid cancer. So these are 0 to 4 centimeters in size. On the right, tumors that are intermediate and high risk. These are much rarer, over 4 centimeters in size. And if you just step back and look at these two figures, you can see the figure on the right, there's a lot of noise, right? But not a lot of change over time, right? There's fluctuations from year to year, but in the end, things aren't going up and things aren't going down. They're pretty much the same. So the management and its impact on high risk and intermediate risk disease unchanged, but look at how much change there has been in low-risk tumors. So this almost certainly reflects changes based on guidelines, which is where all the kinetic has been. And what I'll highlight are two things. One is the black line, and the black line is total thyroidectomy with radioactive iodine afterwards. And you see it is plummeting, that strategy. And that's because the 2016 guidelines took away the benefit of having total thyroidectomy and additionally eliminated radioactive iodine as a recommendation for patients with low-risk disease. And doctors are following those recommendations. So we're using radioactive iodine a lot less. Yellow is total thyroidectomy without radioactive iodine, going way up, because even when patients do have total thyroidectomy, doctors are not going ahead and then giving the radioactive iodine. So really, radioactive iodine is being used much more parsimoniously in 2022. So that's really important for all of you to know. And then finally, this blue line, which all of a sudden is ticking up, and that's the use of thyroid lobectomy for low-risk differentiated thyroid cancer. And that's clearly becoming more and more popular, but is more muted, I would say, than what is going on with the radioactive iodine. So what did we conclude from this study? Radioactive iodine is being used less and less for low-risk disease and in children. And we don't like to use it in children because it can cause cancer later in life, including thyroid cancer. Lobectomy is picking up, as well as non-surgical management, meaning that active surveillance is still looking kind of stable. But what I would say is we clearly need much more evidence and better evidence to inform next stages. So let's come to today and now pivot and look forward. So what's going on and what's gonna go on in the very near future? Well, everything started in 2019 and then the pandemic hit. And I have to say, all of us got waylaid and we were all just trying to stay alive and do our day jobs. So the guidelines writing process has been delayed, but now that things are a little more stable, we are turning back to writing guidelines. Well, big picture. So in 2015-16, there was one set of guidelines for both thyroid nodules and differentiated thyroid cancer. The next iteration of the guidelines will see a division between guidelines driving thyroid nodule management and guidelines driving differentiated thyroid cancer management. So two separate sets of guidelines. The thyroid nodule guidelines are being led by these two people. You may even have heard from them over the last several days. Dr. Susan Mandel, an endocrinologist at the University of Pennsylvania, and Dr. Lisa Orloff at Stanford University, and she is an otolaryngologist and head and neck surgeon. So they're going to be sharing the guidelines for thyroid nodules. And then there are the differentiated thyroid cancer guidelines. And here I'm showing you the authors of those guidelines, because remember, implicit bias, you've got to know who writes guidelines so that you think about the lens in which data is interpreted. And I want to highlight a few things here to you. First of all, I am only a co-chair of these guidelines. I'm an endocrine surgeon, and I'm co-writing them with Dr. Matt Ringel, who is an endocrinologist at The Ohio State University. Our guidelines are really cool, I think, this time. They are very diverse, much more diverse than prior guidelines, which I think is really important. There are men and there are women, which is important. There are many different specialties. There are endocrinologists, endocrine surgeons, otolaryngologists, for the first time, pathologists, for the first time, nuclear medicine doctors, for the first time, a genetics counselor, because some differentiated thyroid cancer is inherited. And perhaps what Dr. Ringel and I are proudest of, for the first time, long overdue, not an excuse, I'm apologizing here. We have a patient representative, and I don't think we could have a better patient representative than Gary Bloom from ThyCa. So I want everyone to know that ThyCa has a voice and an equal voice in how we're writing these guidelines, because we believe strongly that the patient voice and the patient perspective needs to be represented. And this is what I'm saying in this figure. As you can tell from this presentation, there's a lot of evidential equipoise out there, meaning there's evidence that maybe people can recruit to support whatever perspective they have, because overall the quality of the evidence is thin. But in the end, it is the patient who should be in the epicenter of decision-making, and our job as clinicians is to advise that patient. Well, who's writing the guidelines for thyroid cancer surgery? So I just wanted to show you who they are. 2 are endocrine surgeons, 2 are otolaryngologists, Dave Stewart, Ralph Tufano, the otolaryngologist, 2, Libby Grubbs and Drew Ridge are endocrine surgeons. So we're trying to get that balance as it pertains to specialty. Well, what are we doing different to try to make these guidelines for all of you more rigorous and accurate? All of our task force members have been much more thoroughly vetted for conflicts of interest. Many people have ties to industry and pharma, and we need to reveal that to readers and to patients so that you can better judge what is being recommended. For the first time, we have a methodologist on, Roger Chu, who supports the World Health Organization. And that is to make sure that we are looking at the evidence through a critical lens, not through just a clinical lens. And we're calling out the quality of the evidence in a little different way, and we believe in a more transparent way. Well, we're organizing the guidelines differently. And I want you to know this because you're going to be reading these guidelines in 2023. And for the first time, we are focusing on the patient journey. So in the past, the guidelines have been written really from the perspective of the physician or the clinician. We are going as a patient would go through their care, starting with a diagnosis and then traveling as a patient would through the clinical world as they are diagnosed, treated, and then followed for their disease. So we, because we're not thyroid nodules, will begin with a thyroid cancer diagnosis. And the first, straight out of the gates, the first controversy we're going to tackle is, should patients have surgery uniformly, or could they be followed for their disease? Then we're going to be really expanding in the new guidelines about how to risk stratify patients. So this is the concept of personalizing treatment. In the old days, everyone was treated the same with differentiated thyroid cancer. Then we started to think about low, intermediate, and high risk. And I'm going to forewarn you that in the new guidelines, we're going to be even more detailed, bringing in things like molecular profiling and molecular markers to help make sure that individual patients are given individualized recommendations, at least as so far as there are evidence. We're going to not just think about surgery and radioactive iodine and active surveillance. We're going to be thinking about things like ablative therapy, so radiofrequency ablation, which you may have heard about over the last several days, or ethanol ablation will be discussed. We're also going to be thinking a lot about that post-operative surveillance strategy. How often should we be following patients to see if they have persistent or recurrent disease? Should we in fact follow them for the rest of their lives? And we are doing that in many, many patients right now. We don't do that for other patients with cancer. So is there a date when we would say, quote unquote, you are in remission, a word we've never used in thyroid cancer, when we can actually say, you might be cured. We can stop following you and we can maybe even transition you back to a primary care physician or general internist. To do that, we must be able to define response. We must be able to better delineate how we monitor patients. We must better understand all of the different treatment options that are available. And in the end, the patient perspective, especially as it pertains to the cost of their care and the quality of life that you experience, these all need to drive recommendations. So if I were sort of looking into the future, what do I think you're going to be seeing? So I think these are three big areas where I feel very confident you're going to see a change in recommendations. One, active surveillance, how that matches up to thyroid surgery. Two, the use of intraoperative nerve stimulation and monitoring. I definitely think you're going to see a change there. And again, how much surgery to do, like the age-old debate, lobectomy, total thyroidectomy, are they equivalent? Or might one start to emerge again as being preferred? So here, there is already evidence from our guidelines writing group that has been published. So these are online right now. They're already being highly cited because I think people realize that these are studies coming out of the guidelines group. So this is the first time the guidelines group is actually doing science. We are producing science that then will be folded into our guidelines. And this is a piece that was published earlier this year. I'm going to show you two publications already, both in 2022. And here we did a systematic review comparing active surveillance versus thyroid surgery. So we compared active surveillance versus upfront surgery. We started with 719 studies that we reviewed as a guidelines committee. And ultimately, we winnowed those studies down to just 18. You could say, how the heck did that happen, Dr. Sosa? How'd you go from 719 to 18? And that's the whole idea of thin evidence. We had to discard the overwhelming majority of studies because they were so poorly done. And what we found is that the crux of those 18 were really 4 cohort studies, just 4 studies. Now, nearly 90,000 patients that were the epicenter of our data. And what we found is that, in fact, surgery was associated with improved all-cause or thyroid cancer mortality compared with non-surgical management, meaning active surveillance. But those findings were potentially profoundly influenced by patients' age, their tumor risk category, and other confounding considerations. Okay, so there were a lot of things muddying the waters. So what did we conclude from this study? In patients with small, low risk, primarily papillary differentiated thyroid cancer, active surveillance and immediate surgery appear to be associated with similar mortality and risk of recurrence and other outcome. But the methodologic limitations of the study were really, really strong and may preclude strong conclusions. Studies of no surgery versus surgery, therefore, are very difficult to interpret due to all of this confounding and heterogeneity. And ultimately, we clearly need much better research to inform best strategy going forward. What do I think you're going to see? I think active surveillance probably will come closer to the center of discussion about how to best manage patients. Well, what other areas do I think are going to evolve? De-escalation of surveillance, meaning long-term follow-up after surgery. How we think about thyroglobulin levels after particularly lobectomy and total thyroidectomy without radioactive iodine. I think you're going to see an evolution in the management of thyroid hormone suppression, which we used to do all the time and which we are doing less and less. You're going to see for the first time discrete recommendations around NIFT-Ps. And finally, you're going to probably see separate recommendations for Hürthle cell thyroid cancer. Why? Because that is a very different entity from papillary and follicular thyroid cancer. So I'm going to skip this and go to this, which is the second paper that our group has published this year in 2022. Again, you can use your QR code if you want to look up this reference. It is publicly available. And this is looking at how to think about serum thyroglobulin levels after surgery. So as you may know, there for a long time has been a large body of evidence, we thought 827 studies over time looking at thyroglobulin levels after surgery. But you can see, again, in our study, we took those 827 studies and winnowed them down to just 37. And you could say, well, Dr. Sosa, why did you do that? This is why, because the evidence was so bad when you actually look at quality, poor, 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 fair, poor, poor, poor. All of these other things, unclear, meaning the quality of the evidence supporting guidelines was just unacceptably low to inform what we are doing for our patients. And I would say the other big problem for so many of these studies is thyroglobulin levels are being reported historically after total thyroidectomy with radioactive iodine. But I've already shown you that isn't how we're managing the overwhelming majority of patients with differentiated thyroid cancer in 22. Remember, radioactive iodine is going away for low-risk disease, not for intermediate and high risk, but for low-risk disease. And thyroid lobectomy is coming online. So patients aren't having total thyroidectomy at the rates they were in the past. So the evidence for thyroglobulin now needs to be assembled in those two new clinical scenarios: after total thyroidectomy without radioactive iodine and after thyroid lobectomy. So following partial thyroidectomy, what we see from this literature review is that thyroglobulin measurement was not accurate for diagnosing recurrence or metastasis, or estimates were quite frankly very imprecise. And following total thyroidectomy without radioactive iodine, evidence was at best limited to there being so few studies with such low rates of recurrence and metastasis, making conclusions precarious. So where did we finish that very important meta-analysis? There's very limited evidence suggesting low utility of thyroglobulin measurement for identifying recurrent or metastatic disease following partial thyroidectomy. That is a huge conclusion. After total thyroidectomy, probably thyroglobulin levels with a cutoff of 1 to 2.5 nanograms per milliliter might identify patients at low risk for persistent and metastatic disease. And again, there is a call for more science to inform our approaches going forward, especially as we are doing less surgery and less radioactive iodine. So where do I want to finish? And we're going to be ready for questions. I tried to save about 15 minutes to hear what all of you think and what questions you have to challenge us. I guess what I would conclude is change is coming. And I think change is bad and uncomfortable if there is no evidence to support it. But change is good when the rate of change is calibrated to allow all of us as physicians and clinicians and patients to catch up and understand that change. And if the evidence supporting it is good. And I hope what you will see today is that the group of thought leaders who we have assembled are broadly representative, including representative of all the different specialties now that care for patients, because multiple perspectives are important, including, and most importantly, the perspective of the patient. And there is no way for one patient, for poor Gary Bloom, to represent all of you. Let's be honest, that is an impossible task, right? Even if he was Hercules, he cannot do that. But what we hope is that ThyCa is an avenue, a vessel to channel patient voice into Gary, and that he can bring, whether it is consensus or disagreement, to the table as we craft our guidelines such that they are reflective as much as possible of all of you. And so here's the way the guidelines writing used to look. It was like A to B, super easy, seems straightforward. This isn't hard. And then there's life, right? And my and Dr. Ringel's perspective is the lower path is the more accurate one. It's a mess. Data is really hard. We got to be thoughtful. We got to do the best we can in as impartial a way as we can. And we as scientists, Dr. Ringel and I, we spend a lot of our time doing science. And by these two publications, and I think you're going to see another one coming as well before the guidelines are published, we're trying to do the science in real time such that in the end, there is currency to the conclusions that we reach. And you could say, well, Dr. Sosa, who are you? I don't know you. Well, you know, I'm a complicated person, but this is where I practice endocrine surgery at the University of California, San Francisco. This is my professional family. I don't think there are better endocrine surgeons or thyroid surgeons in the world. We're very blessed. We are very diverse, as you can see, very diverse. We have very different life stories, but we come together as a family and a team to try to provide the very best care of our patients. And I joke, this is not the way we look. This is the way in the old days people look, you know, in these old diagrams and paintings, and they're super cool, but we try to be very contemporary. And I think that's what change is. It's about being contemporary. And I also am blessed to be chair of the Department of Surgery at UCSF. And I always show this because this is who buoys me every day. And what is unique, I think a lot of people think surgeons are oh so growly and they're mean and they never smile. But at UCSF, we're a very happy group of surgeons because we love what we do. And hopefully you have felt today some of that passion that we have in the Bay Area. So with that, and that's my Twitter handle. If any of you follow me on Twitter, you know I often have something to say about something, including thyroid cancer. So that's where you can find me when I'm not writing about thyroid cancer. So with that, I will stop sharing. Thank you so much for the privilege of talking today, and I look forward to your questions.
Dr. Sosa, thank you. Amazing, a lot to think about. We have 21 questions and 7 minutes. So
Okay, what's the first one?
Criteria for active surveillance.
Yeah.
Current.
Yeah, will there, so I see from Jackson, thank you for your question. Will there be any changes? Yes, there will be. There's going to be a lot of changes. I can't really say, so there's a lot I can say, but probably there's more that I can't say. And that's because our group, we're meeting pretty much every other week. Guidelines are being written, draft guidelines are being written, and literally in the moment they are changing. We're going to be meeting, a next milestone will be in October at the American Thyroid Association meeting in Montreal, Canada. We're going to be finalizing some of the guidelines. I would say the guidelines our goal is to have a set of draft guidelines that will be circulated for vetting by the membership of the American Thyroid Association. So We're going to write the guidelines, draft them, then we're going to circulate them to the membership of the ATA. And I'll be honest with you, they are often more critical than peer reviewers. Then the guidelines will be submitted to the journal Thyroid. That is where they will be published. We are hoping those guidelines will be published summer to fall of 2023. So that's big picture, but Jackson, there will be changes for criteria. I think the upper limit, stay tuned there, stay tuned. Let's see, what's the next one? Can you speak to the latest recommendations informing thyroid hormone replacement dosage? What factors are considered? So there are many factors that are considered. Importantly, you know, as you probably know, we think about age. Age is a very important one where when you're young, you can tolerate more than when you're older and you maybe have heart disease where you can't afford to be hyperthyroid. So the range of normal of TSH is sort of broadened at the age extremes. We use optimal body weight with some titration. So unfortunately, I and many other Americans are not as slim as we wish we were. And so we have to think carefully about BMI that goes into it. And then the third factor where you're going to see a change in our lens, and I alluded to this, is suppression. So for many, many years, we drove TSH levels down into the ground for everyone with differentiated thyroid cancer. And then what we discovered is that patients weren't getting any benefit. Many were not getting benefit, but they were sustaining significant complications from our treatment, like osteoporosis, like heart attack, like stroke. And so we have now more and more defined strictly where suppression is appropriate. And I think you will see the chains move down the field with regard to suppression. Okay, quick question regarding what's considered metastatic disease regarding spread to parathyroidal nodes considered metastatic disease. Yes, so definition of metastasis has not changed, but what is changing is what we think is significant versus less significant for metastatic disease. Now, our colleagues in breast cancer are way ahead of us here. They've been thinking about this much longer than we have. And the example I would give you is micro versus macro metastatic disease. And should we be thinking about a patient who has, I just did last week, a massive operation on a gentleman who had a 9-centimeter metastasis of his papillary thyroid cancer. Is that patient the same as a patient who has a 2-millimeter metastasis in the lymph node? Well, up until now, technically speaking, they are equivalent. They are not equivalent in real life. So you will, I think, again, I don't hold me to this, but I think you're going to see a change in how we think about metastatic disease that is macro, meaning large, versus micro, meaning invisible to the human eye. This is not a new concept for other cancers like breast cancer. It will be a relatively new concept for thyroid cancer. When we talk about survival rates, is it always a 5-year survival? No, I would actually say the shortest interval I kind of think about at a population level is 10 years. We typically talk about 10 years because fortunately, papillary thyroid cancer and differentiated thyroid cancer is associated with superlative survival in excess of really 98% probably at 10 years. So if you're at 5 years, it's even higher. So I generally say in excess of 95 to 98% at a decade. How do these recommendations differ for children? The recommendations I've shown you today do not, repeat, do not pertain to children. The American Thyroid Association has issued separate guidelines for pediatric thyroid cancer. They are publicly available on the ATA website. And the process has now begun to rewrite those guidelines. They're behind us by a couple of years, a year or two. So I'd be looking for the children's guidelines to come out maybe 2024, 2025. This one I'd like to skip maybe. It's just a little too personal. Let's try to keep things very high level. Will there be consideration about non-surgical treatments? Yes, there will. RFA, ethanol ablation. You're going to see those discussed, at least as a high level. I'll be honest with you, data still super limited, okay, super limited. So any guidelines I think you see will be relatively weak, but I think you will see those discussed. I'm going to skip the next one, a little too personal. This is positive steps for low risk, but it seems that nothing will change for intermediate. No, things are going to change for intermediate and high risk cancer. Thank you very much for this question. I've chosen in this presentation to talk to the majority of people just because 45 minutes, I'm sorry, it's too short a time to talk to everyone. It's too short a time period. Like I could talk to you about these things for the rest of my life because I love them. They're controversial. But there are going to be guidelines targeting intermediate thyroid cancer as well as high-risk thyroid cancer. Dr. Lori Worth is our medical oncologist who will be really evolving our guidelines in a very major way, particularly around small molecule therapy for high-risk differentiated thyroid cancer. I think you're going to see this area bulked up by 500%. It will reflect, and because this is the most kinetic area of differentiated thyroid cancer, it's going to be the last one we finalize before going to press. Every day, it seems, there are new clinical trials coming out. It's perhaps the most exciting area. But because it's so kinetic, I chose not to focus on it. But yes, there will be specific guidelines. And I would say highly personalized, right? Targeting, these are targeted small molecule therapies based on the molecular underpinnings of the tumors. So stay tuned there. No oncologist, Lori Worth is an oncologist, okay? So there are oncologists. I'm a surgical oncologist. I'm trained in surgical oncology, as are Dr. Ridge, Dr. Grubbs. So there actually are a number of oncologists on these guidelines. Are there updates on tall cell variants? It's hard to answer the question based on the way it was asked, but I think what you're asking is, are we refining how the guidelines are written for histologic subvariants? And the answer is yes. And the biggest example, of course, is Hürthle cell carcinoma. Tall cell is pretty rare, you know, like columnar tall cell, diffuse sclerosing. So there'll be some treatment of that, but more through the molecular underpinnings targeting mutational profile of tumors. I think these updates are wonderful. It's tougher, may have been overtreated. Is the research showing that people diagnosed? We haven't really looked at that, and I look backwards, you know. I think that's not the purpose of anything. And maybe I'll make this the last question because they're about to give me a hook. You know, don't look backwards. I think all of us do the very best we can with the evidence we have. And what I did, and I'm not an old person, maybe I look cryopreserved, I'm not that old. What I did in my practice 20 years ago is very different from what I do now. We are doing the best we can. And I suspect that what we are doing now will again not be what we're doing 20 years from now. And what I think we all just have to commit to is every day re-examine the evidence. And if what we're doing appears to be the right thing, continue to do it. But if it does not appear to be the right thing, let's agree we're willing to change. So maybe we'll finish there.
Okay.
Bill, I don't know if there's...
Dr. Sosa, again, thank you. Thank you very much. Wonderful. Just a wonderful presentation. It's always so informative to listen to you speak.
Great. All right, well, listen, everyone, thank you so much for your questions. I'm sorry I couldn't get to all of them, but I'm at ThyCa pretty much almost every year. I'm on the web, I'm on Twitter talking about different things. Look at the science that we're involved in. 2023 is going to be a great year for differentiated thyroid cancer. I'm excited about these guidelines because I think we're going to improve patient outcomes. Have a great weekend too.
Thanks,
All right,
everybody.
everyone. Thanks so much for having me. Stay well. To good health in 2023. Ciao. Bye.